So now we have anesthetized the patient is on table. The first thing is, we come to is position. So again, the mobile bearing group, the Oxford group, emphasizes on using a hanging leg position. The fixed bearing group, they are not too concerned about it. They usually say you could go with the standard TKR position. So I would like the esteemed panel, Ashutosh, Bhupendra, sir, and Nikhil, if starting with Nikhil, how would you decide on what is a right position for a particular patient?
See, when we started with this kind of surgeries, unis long time back, actually we started with, because we are trained with the Oxford group, so I think we started with a hanging hip position. Okay. But over the period, because we need to convert these unis sometimes to the TKS, and hanging position is much difficult, so we started doing in a on table position, like a TKR position, and that is the commonest position which I am following right now.
Yeah, same with me, because initially I used to do Oxford only, and the typical their theory is like in hanging position, but with the now I'm more towards fixed bearing, so that is on TKR position, and even last few Oxford I did in the TKR position.
Okay, so yes sir.
Yeah, so few points. This Oxford clamp, this leg holding clamp, they were having it from the company side initially.
Correct.
Now it is not available, and not easily available. Like if you any beginner who goes and asks for that clamp, they will not be able to give.
Correct.
That is number one. Second, if you want to customize, you cannot match that quality. True. That all those sturdiness and all those things. So what happens is, you go and get it from a local shop and try to do it. It is fiddly. And
Correct.
the moment it starts fiddly, then you get jittery during the surgery. Oh, this is shaking, that is shaking, all those things. So what I will suggest is, don't rely too much on the clamp or leg holding position. Straight away we can start with the regular TKR position. Only thing is, we have to lift the thigh, not under the knee, keeping the hand under the popliteal fossa, but exactly under the tunicate. You lift the thigh nicely, try to lift, take the cot low enough, the whole table low enough, and then lift the leg so that the leg hangs down under the assistant's arm whenever you want to lift it. So that one, and whenever you don't want, just keep it as the TKR position. So that will suffice for even a mobile bearing or a fixed bearing, both. So that is not a contraindication.
That's a brilliant point. I think this whole thing, this discussion is to recreate that MCL tension, and the Oxford guys got this leg holder for that, getting that MCL tension with gravity. So like sir mentioned, that's an excellent tip, just the assistant holding, lowering your table, lifting up the femur at the thigh level, so you can sort of recreate it even for your Oxford
and
cases.
This TKR position is better for bilateral cases.
If you're doing a bilateral, you need to convert in between to a total knee, then you're always safe with a TKR position. Then the incision. So again, like as a surgeon, if I'm starting off, what do I do? I've been doing TKR for the last 5 years maybe, and I need to convert to UKR. So do I start off with normal standard midline incision, get a few UKRs under my belt, and then play around with the incision depth? Or this is an incision through which I should learn from day one, so that because finally the advantage of the UKR is a minimally invasive procedure. So again, starting with Ashutosh, how would you go about that?
I do in the just midline approach, extend the skin incision till the upper border of patella, and deeper incision till I do all my cases in hanging leg position. So the incision going proximally till the patella subluxate laterally easily with fingers. So that is my extent of indication. It depends on the patient, how obese or thin patient is. The midline one, it is helpful for me, because if I need to convert it to TKR, just extend it proximally. Okay. So but that's what my logic is, rather than the slight oblique incision.
You're not doing the oblique
no,
incision.
I'm not doing it
the
oblique.
Straight
just
incision,
straight,
but a minimally.
Yeah, it's sort of a distal half of your routine TKR incision.
TKR, okay. Natation, sir, about the incision?
Keep it very simple. You don't need to have a separate incision for a uni and then separate for a TKR.
Okay.
To start with, keep it in the midline. Then you can go slightly when you have become more and more experienced with cases, then you can minimize the length and then may go a little more medial also when you are confident. But a midline incision should be suffice, and it is basically the medial parapatellar arthrotomy which is going to matter, and then that one you can do it even with the midline. So I think midline should be, and don't hesitate to extend it up or below, thinking that, oh, I should not put a big scar. No, that is not, should not
True,
be there.
true. So, Bhupendra, so sir was mentioning about the arthrotomy. So, do you do parapatellar or do you extend into
From my
mid-vastus?
first case even, I have used mini arthrotomy only in oblique
Okay.
incision.
Okay.
So if I required, say a week before, I had a case where he was the father of doctor, one of my friend. So I opened with mini arthrotomy, but he had absent ACL and lateral wear also. So that incision I curved towards lateral side. So it is a slightly curved incision, but that is okay. So there is nothing harm in putting slight oblique incision.
Oblique incision as
Yeah,
well.
yeah.
And you're perfectly able to see the
Yeah,
lateral
yeah,
compartment in
100%.
that.
Yeah.
True. Nikhil? Yeah.
My simple strategy. Basically, I take a midline incision for the skin, but when I'm doing inside, if I'm pretty comfortable, I know that I'm going to do the unis with patient. Actually, it's a very parapetial approach. If at all I have to convert, I just take a subvastus in that.
Okay. So I think the point is always try and stick to your, the routine. It's like you know a way how you drive there daily. So you know the anterior standard midline incision. So when you're starting off with UKRs, I would suggest taking the anterior midline, and then you could sort of, adjust that and bring the size lower. But in the initial stage of your practice, just try and stick to the midline incision there. And then I think the most important part of the UKR is the tibial cut. Once you get the tibial cut right, I think everything falls into place. And if you get it wrong, then things could go haywire. You might even have to convert to a total knee. So the tibial cut, so the points to look at is the coronal plane, varus valgus, the slope, the depth of the cut. So again, I would like to start with Nikhil. So if you're doing, looking at the standard tibial cut, what are you looking at? Dead neutral or a little bit of varus, or what are your tips?
When you're as Dr. Sinu said, it's all depend on your tibial cut. How you take the tibial cut, everything, all systems depends on the tibial cut, and the surgery just follow the tibial cut. So first important cut is one tibia, one is a vertical cut and one is a horizontal cut. So when you are talking about the horizontal cut, that should be a perpendicular to mechanical axis, that is mandatory. And another thing is the slope while taking in that. Okay, so normally the slope is dictated by the company instrumentation, whether it is 7 degree, 8 degree, whatever. Or else you're doing a manually, you just follow what the company instructions are there. Or else normally we don't prefer more than 5 degree slope if I'm using the robotics or a navigation. That is the first thing. And the other vertical cut, it should be an axis of my flexion. So I take my vertical or recip saw and I aim towards the ASIS or a center of the hip, and I take the knee to the range of motion so that my vertical cut should be in the flexion axis all the time. And it should be skirting just next to my ACL. Okay, that is one thing. And you have to take a precaution. You should not cut a posterior cortex at the PA, because that is more important. Even your horizontal cut go underneath of your spine of the ACL, it doesn't make any difference. It doesn't cause a fracture. But as soon as you take a posterior cut and if your posterior cut goes in the posterior cortex of the tibia, there are high chance that you're going to land up with the fractures. And that is care. This is the care you should take while doing this tibial cuts.
Very, very true. I think that's two very important messages there. One is make sure that you don't breach the posterior cortex. So when you're holding your saw and taking a cut, make sure that your hand is not lifted. So if you lift your hand, you're going to cut on the posterior tibial plateau. And other very important thing, of course, is making sure that you're going as laterally as possible. A few fibers of ACL being cut is perfectly okay. Nothing is going to happen there. But if you don't go lateral, you are going to stay medial. Two things. One is you're going to have a smaller size of tibia, and it is known, especially in Oxford, small tibias can dislocate. So just try and maximize your tibial size by going laterally. It has better bone coverage as well, and also the femorotibial tracking is better when you go with the tibial implant laterally. Sir, Bhupendra, sorry.
So there is
Anything about the depth of the cut? Yeah, you
Yeah,
go
so
ahead, please.
there is one tip that I usually pass 5 mm osteotome just beneath the PCL.
Okay.
PCL medial and medial femoral condyle. You just pass the osteotome and keeping it at it and then flex the knee.
Okay.
So that will give you idea that in what direction your recip cut will go, and connect that with anterior root of meniscus, medial meniscus footprint.
Okay.
So if you draw a line, that would be 100% every time perfect vertical cut.
That's perfect. Yeah, yeah. You don't need a navigation for robotics for that. So that's an excellent tip again. So you could meet him later and exactly find out how he does it. So very, very good. So Rajkumar sir, about the depth of the cut, what are you looking at cutting in a standard EMOA?
Like as minimal as possible should be the right message, but you have to go by the system. I will say know the system thoroughly and don't go by the reps what they casually say. You know
Very
the
true.
system, because some guys will say, sir, no, I saw that. You take 3, sir. That will solve the problem. You say 2, sir. No. But that too, when you are a beginner, they will try to do the surgery orally before you even open the knee.
Yeah.
So you have to be careful that part. So you
Yeah.
need to know the system, first point. Second point, don't try to take too much of bone initially. Try to, initially to start with, take the right and then see. Maybe if you are undercutting, no problem. You can even take the blade little bit again, shave it off little more extra. But in uni, if you take too much of bone initially, then the problem starts. Then you try to put a bigger insert, then you're overstuffing, so all those things. Even if you're little bit tight, you can take a more bone. But if you have taken more bone initially, then it becomes a problem.
And even more cut will lend us in that soft cancellous bone. So that will subside. Yeah.
Yeah.
I think that is the principle or logic behind the hanging leg position, what Oxford mentions. That let the gravity and ligament tension dictate when you put the spoon and apply the tibial jig. So the putting the zero shim and let that dictate your tibial cut rather than measuring 1, 2, 3 mm like we do with the stylus and the TKR.
Yeah, so that is the Oxford instrumentation. I mean, it's highly specific as compared to people who do fixed bearing where you're just eyeballing a lot of it. The Oxford has got very, very specific instrumentation. And like Ashutosh mentioned, when your MCL is completely stretched out, you just need to put in the jig and it'll let you know exactly the amount of bone that needs to be cut. Again, a learning curve there. Again, very important, try and get your cut either in neutral or a little bit of varus, but never in valgus, because the moment you go into a valgus cut, you're going into the soft metaphyseal part of the bone. And if you have breached the posterior cortex, you can develop a fracture there on the medial condyle. So a little bit of, so again, varus, it is very easy to say but if you're using technology, it becomes much more easier. But if you're just doing a blind varus cut, it's a bit risky. And now coming to the femur position, it's usually jig based. So like the Oxford has got an intramedullary kind of device which will guide you for the jig, but then you have to try and always get the femur absolutely perpendicular to the tibia. So again, starting with Nikhil, how do you draw a line perpendicular to the tibial cut and then try and get those 2 peg holes to match to be perpendicular?
See, if you see our knees on a flexion, okay, and if you see the femur in the coronal view, it's always inclined. There's a tilt after 10 to 15 degree, and that is why you try to get missed because of this alignment. So what I normally do, I take a center of the femoral condyle at the bottom posteriorly, and I mark a tide mark anteriorly where the tibia is getting. When you do extension, the point of the tibia on the femur I mark. So these 2 points are always connected, and I try to keep my alignment on that line only. So whatever system I'm using, so that is my femoral prosthesis axis all the time. If I'm using actually with Oxford, I think they're a good link bar, and that always gives you a good alignment. But when I'm doing a fixed bearing, like they don't have landmarks actually.
Correct.
So I'm not using the robotics. I think I follow this philosophy.
Yeah, so again, very important. If you're doing fixed bearing designs, they are like the Oxford has got excellent instrumentation. You can just follow that. Whereas the fixed bearing standard designs without robotics, there's a lot of eyeballing involved. So you might have to depend on, tips like this where you have to, maybe draw a, line and then try and match the peg holes with that. And it's okay in an Oxford because it's a completely congruent surface. So a 5-degree coronal malalignment here and there is fine. But in a fixed bearing, you could have something called as edge loading if you don't get it correct. So now coming to the balancing and alignment part. So Natation, are you looking at it to be completely tight throughout the range, or you want a little bit of laxity in your UKR?
I will say that rather than tight or lax, I say a stable joint should be the right word. So, because the moment you try to feel for lax, that depends surgeon to surgeon. He might feel little lax, the other surgeon might say, oh, it might be tight. So it is very difficult to gauge that and then teach everybody like that. So it is, you have to practice your own way of assessing that, and it varies from case to case. So having said that, reasonably stable, first point. Second point, your alignment should decide the stability. Like you're not going to correct anything here. You're not going to correct the deformity or anything. You're going to only resurfacing. You're only doing the removing the damaged bone and putting in an implant. So that means what? You're not going to take the knee into neutral or into valgus position. You're going to keep it in the same alignment what it is. There will be 1 or 2 degrees of correction and the limb might look straight after the surgery. So having said that, that should be your aim. If you have that aim, this will not come to a problem.
Correct.
How much of looseness it has. See, another thing what I will also suggest is, in regards to after anesthesia, you examine the patient. Preoperatively, you might feel, okay, 5 degrees, FFD is there, but all these Indian females, after anesthesia, you will see that it goes into hyperextension.
True. Yeah.
So we didn't, in fact, we didn't talk too much about this hyperextension part.
Yeah.
In fact, I will suggest if there is a reasonably a good hyperextension, better not to do. I will suggest not to do a uni because those patients are tending, they have the tendency for hyperlaxity. After the surgery, even if you do a TKR, after the surgery, you will see that they are stretching out gradually. So in fact, in my cases, even in a TKR, if the patient has got a hyperlaxity tendency, post anesthesia, if there is a hyperextension, I tend to keep the knee little tight. So you have to make sure all these points and keep it stable joint.
Because once you start reading the Oxford handbooks, you'll see that they mention a lot about 2 fingers, holding it with a grip, holding it with your entire hand. So it's like Sir mentioned, it's very subjective, but that's a field, that's the part of the learning curve where you have to understand what is good enough. And unfortunately, in the initial part of your practice, the fear of that poly spinning out in an Oxford, you keep tending to put in higher polys and thicker polys. And what you would do is we could go into neutral or we could go into valgus and then cause arthritis in the opposite
and the
compartment.
Rest of the faculty, anything regarding hyperextension, like what is in your practice? Do you do uni for?
No, I don't do the unis in hyperextension. So pre-operative clinical examination extremely important for you.
No, but not just so I've started using the robo recently, and the robo picks these hyperextension deformities very well. So after using the robo, I have had to convert few unis to total. Otherwise, if I was doing conventional, I wouldn't have, because that hyperextension is something that's scary for
point.
But one point actually. So hyperextension detected by the robo is also determined where you take the points actually. If you're not taking intra-articular correctly, registration, many times it either show the flexion or a hyperextension. That you have to take care. You should not rely. Basically, a hanging point, you take on a bone, inside the bone, we done a lot of registration point kind of things, and everything the axis changes.
Correct. And
So
it's
it has
also
to be standardized in that way actually.
One more thing what I will say is, see, all the Oxford groups, indications, contraindications are all not devised or tried in our patients. It's all for Caucasians.
Absolutely.
So our patients' demography, the race, everything is totally different. Our female patients they'll have all sorts of this thing. So you have to be very, very careful in selecting the patients. See, I've seen a lot of cases being done, and if you ask the Oxford group when they come here, You can try, you can do. Sir, can we do this for this? Yeah, you can do, no problem, you try. So it's easy for them to say try, but I will suggest to at least to begin with,
stick
on
to
the right indication.
Because we are looking at our cases of patellofemoral pain. Like in between, I had gone completely Oxford, and I was doing Oxfords or even patients who came with knee pain because the Oxford guy said is fine, and just there's no lateral subchondral growing. And I've had at least 10 patients now who have anterior knee pain in whom I have done Oxford, and I'm at a fix. And so now, if the patient is symptomatic patella wise, I'm not offering Oxfords to them. So this is Indian patient
one more
context.
message out of this UKR session should not be like this. UKR session should not be do more UKRs, do more UKRs. This
The
session
right
should
indication.
be mainly do the right cases, the right way. That's all.
Absolutely. So, excellent point. So again, very important to understand tibial cementing is extremely important because that's the one of the commonest modes of failure in unicompartmental. Ashutosh, any points while you're cementing your tibial component?
Commonest mistake initially we all make is put a lot of cement. So usually guy give maybe 40 gram, even a 20 gram cement packets are too much for any uni. So just keep cementing, very less cement apply. Oxford instrumentation, they have special applicator or any sort of spoon. So I usually first apply cement on from posterior to anterior part of the tibia, remove the excess cement beforehand only. For femoral pegs, I usually put cement in liquid stage with a say 2 cc syringe in the peg holes.
Okay.
And then apply very minimal cement to the underneath of the tibial plate as well as to the femur. While after putting the tibia, they have a special sort of cement remover hook, which is one side is perpendicular, one side is oblique. So it helps in removing the cement on the posterior parts as well as in the medial side of the tibia.
Yeah, so the take home is to have less cement posteriorly, more cement anteriorly. So when you make a wedge kind of thing on the underside of your osteotome and then apply it, and then put in your component with the posterior part contacting first, so that you do not express cement out posteriorly. If it goes posteriorly, it is very difficult to
remove it, and if it remains there, then it is one of the causes of impingement again.
Especially in a mobile bearing knee. It's not just for cosmetic radiology cosmesis, taking the cement out. Here, if there is a cement that has come out, slightly proximally, it can actually push against your poly and cause it to spin off. So you have to take it out. So that cementing part is again very, very important. And just to end again, sir, I would like you to, okay, I'll ask Bhupendra. What do you let your patients do after UKR?
I just tell them the cautions.
Okay.
So I give my examples. If I have undergone the same surgery which I have done on you, what precautions I will take. So if required, I can sit on floor, but as minimum as possible. Don't take this as in routine life. Once in a while you require, just don't worry, you can sit.
Okay.
But not routinely, because that would affect your longevity.
Okay. So I think true. So squatting, it's quite comfortable for these patients, but we have to tell them the effect of it. You can have a polywear, and impact activities are completely no, right? Because some of these patients, especially when you go through Western kind of advertisements of UKR, some of these guys are doing playing sports like triathlons, and there's this few videos that come up, and so there are patients who have asked me that. So I'm very
match their bone with our bone.
Yeah, that's what.
Their smallest size is 5'6" in a TKR.
TKR,
That
true.
we use a 5'6". So that means the bone, the size, everything matters.
Yeah.
And they do surgeries for early arthritis or even not even arthritis. So their bone is strong. And you put in we do in osteoporotic cases, and you do all this joggings and runnings, then it becomes a problem.
So it's absolutely what we as surgeons, we have to explain that to a surgeon as to what precautions that needs to be taken. But it's definitely an implant that gives patients much more freedom as compared to a total knee. It's a much safer procedure, And it's something that, like sir told, it's not that we should jump onto doing unis, but if you make the correct selection, I think there are enough patients out there where you can select and do enough numbers of uni, because the uni numbers is what is most important in your results. If you're just doing 1 or 2 in a year, you might not get those kind of outcomes. You have to do at least, the Oxford group, the magic number is between 20 and 30, at least 30 in a year, and that's when you get survival rates as good as a total knee. So with that, I think we have a uni session downstairs now, but we can take a question if anybody.
The question is to Bhupendra actually. What made you to change from mobile bearing to fixed bearing?
Because in the Oxford, sometimes sizing is an issue.
That's what I told yesterday. Yes.
And that fixed bearing which I am using has multiple sizes. It has vitamin E poly.
I'm not against that. Actually, it's correct. But Oxford has already given some criteria as to whom you should offer and what size you should offer. Actually, so you know that before as well in hand. I'm just only the sizing is your concern, or any other concern? What make you from shifting from mobile to fixed? Do you find any more advantages of fixed bearing over the mobile, or it just a practice?
Doing fixed bearing, I am a little bit calm post-op. So that's the reason. The position of surgery.
Yeah.
So in say my 20-25% cases, I have already beforehand explained patient that on table I may change decision to TKR. So in that cases, the position is the same. So that is okay. And once I started judging it, that fixed bearing which I am using, and then ultimately it has a similar, I would say it is the fixed bearing version of Oxford.
The one that is.
So that's how I didn't have much added steps.
So you're
And
talking
it is a
about
milling system only. Yeah.
The
So it's a milling
consensus.
system only.
Tux consensus. So if you understand, the femur preparation is done by milling.
Yeah.
So it is
that
the only fixed bearing in which you do a femur
Yeah.
press. So someone who's doing a mobile bearing, you can easily shift to that.
One advantage is positional resistance. So it doesn't correspond contact. So
Yeah.
if you have a bit of like a
Malalignment there. Yeah.
Yeah.
So
what's your opinion, sir? Fixed or mobile?
See, two, three things. If you go by the literature, if you want Oxford as the best, you have literature there. If you want fixed bearing, you have literature there. So having said that, if you're trained in Oxford and if you have attended the course Oxford and if you're confident enough, I will suggest go and do Oxford. It's fantastic system. There is no doubt about it. But whenever you're doing a small, short female patients, you have to be little careful in selecting the tibial tray size. That is the second point. Third point, technique wise, if you are confident, again it is one of the best system. There is no doubt about it. And all this spin out and all those things is not that scary. Actually speaking, it is not scary if you're following. Having said that, when you're doing, slowly people are moving towards robot and more robots are being sold everywhere. And if you are in the pipeline of buying a robot, then better to slowly switch over to a fixed bearing, because Oxford doesn't support a robot. So that should be your...
yeah, excellent point. So I think that's the right way to conclude. And I think I have a 7-minute talk downstairs on fixed versus mobile. So I think so thank you, delegates, so much for your patient listening.